All right, I think we're live. Welcome, everyone. My name is Richard Wiley, and I am the CEO of Glaucoma Australia. Welcome again to another exciting live Q&A event. Tonight on a subject that I know many of you will be very interested in, and the title of the, or the topic of the event tonight, the expanding options in surgical management of glaucoma, which procedure is best for which patient. I'll take this opportunity to welcome our very, very special guests, Associate Professor Mitchell Lawlor. Welcome, Mitch.
Thank you.
Mitch is actually joining us all the way from London tonight, so thank you very much for making your time, and particularly at an upside down time of the clock for you over there today. So just a little bit about Mitch before we get going. So Associate Professor Lawlor is a glaucoma surgeon and specialist in diseases of the optic nerve. He has a PhD in bioethics from the University of Sydney and completed his ophthalmology training at Sydney Eye Hospital. He also spent a further 3 years in subspecialty training, completing dual fellowships in glaucoma and neuro-ophthalmology, both at Moorfields Eye Hospital in London. He is a consultant ophthalmologist at Sydney Eye Hospital and a clinical academic at the University of Sydney. He's also the chief investigator of Fight Glaucoma Blindness, which is an international registry of glaucoma outcomes that provides real-world evidence of the safety and efficacy of a range of glaucoma treatments. So very happy to have you as part of the presentation tonight, Mitch. So thank you very much for making the time.
You're welcome. It's lovely to have the chance to chat. I'll just bring up my slides here.
Fantastic.
All right. So I think they should be up and running. And Richard, just you can see those okay?
Yep, perfect.
The other question I have for you is, can you see my mouse pointer moving around there or not?
I can't, no.
Okay, that's fine. I'll just use verbal cues. So, all right. So the first thing I just wanted to mention is it's always good in this situation to know where the speaker's coming from and if there is any relevant disclosures to disclose those. So I will be talking about a couple of products that are either manufactured or distributed by Glaucos, which is a company in this space. I have not received any personal funding from Glaucos, but my research team has. And so just important to be transparent about that at the outset. So really, I think I want to try and keep things fairly simple throughout this presentation because I think it's a bit easier to understand the space. And it may mean that I'll gloss over a few things, but in the Q&A, we can flesh that out a little bit more if there's questions that people have. The way I think of glaucoma treatment in general is really in three categories. The first category is medical treatment, and for the most part, that is drops. And I think probably everybody on the call here is pretty familiar with drops. And there's really a lot of people who have glaucoma who can just use drops, maybe one a night, and their glaucoma is beautifully well controlled and they're perfectly happy. And that's certainly, there is a group of my patients that are very much like that. However, there definitely is a subset of people who have some side effects from the drops, and it can really make things a bit unhappy. Certainly redness, irritation, even remembering to get them in can be a bit of a challenge sometimes. So that really leads into the second category of treatment, which is laser. And here I'm just looking at open angle glaucoma, and this is called selective laser trabeculoplasty. And this procedure is one that we've been using for quite some time now as a way to minimize drops, or even now really use instead of drops is a consideration in a lot of patients. And that's the second category that I'm not going to talk about tonight. So I won't talk about medications. I won't talk about laser, but I think it's important to understand they're there. Really tonight, we're going to focus on the third category of treatment, which is glaucoma surgery. And again, to make it quite simple, I'm going to break this down into just three categories, and we're going to chat in a bit more depth and a bit more detail about each of these three categories. So the first one is actually cataract surgery. Now, this has been a bit of a change, really over the last 10 years. The benefit of cataract surgery on its own for treatment of glaucoma has become a lot more evident. And in fact, cataract surgery is now the most common surgical procedure that I do for glaucoma, and we'll discuss that. The second category is what I will refer to as cataract plus procedures. And this is where you do the cataract surgery, but you also add something else in with it to try and get a little bit of extra pressure reduction on top of the cataract surgery alone. And then the third thing we'll discuss is filtration surgery. And what that means is essentially, this is the procedure that's hard to pronounce, the trabeculectomy. And this tends to be when the glaucoma is getting a bit more advanced or we really need a big pressure drop. That's where we start to look at filtration surgery. And so over the next 10 minutes or so, I'm going to really just break down these 3 different categories and have a chat about when we think about them and who benefits most from them. So let's just start with cataract surgery. So it's quite interesting that I think it's one thing, a lot of people will have heard of cataract surgery, but there's quite a bit of misunderstanding as to what, in fact, a cataract is. Some people think of it as a film across the eye that's torn off. But I won't go into too much detail with anatomy here, but essentially, if you look at the far left of the picture, there's the curvature of the cornea, which is the front window of the eye that you can touch. And then moving to the right is the iris, which is the colored part of the eye. It's a bit hard to see because it's on the side here. And then behind that is a clear football-like structure, and that's the lens of the eye. Now, when we're all young and beautiful, the lens is nice and clear. Lots of light comes in and we see very well. As we all get a bit older, you can see there that lens is starting to become a bit cloudy. I'll just go back so you can have a look. And that area there that's becoming cloudy is that football-like structure called the lens. And then as it becomes even more cloudy, you can start to see that it really becomes opaque. And there's a photo there of someone with quite an advanced cataract. And what you're seeing there in the image on the right is that lens, which is behind the iris, has become opaque. In fact, that's become white. And they're the sort of cataracts that we don't see so often in Australia, but certainly when I'm working in East Timor or in Cambodia, that's the sort of cataracts which are much more common. Now, how does this relate to glaucoma? So when we do a cataract operation, what we do is we actually remove that lens. We leave behind the scaffolding of the lens, which is around the outside, but we take out all of the lens substance and we replace it with a very thin plastic lens. And you can see there in that yellow line is that lens that is placed within the scaffolding. And the main thing I want you to notice is see how much difference the width is of the lenses. The natural lens is really quite thick, whereas the intraocular lens or the new plastic lens is very thin. Now that's relevant for glaucoma because what you can see here is a picture, a scan of somebody's eye. And again, on the left of that black and white image, you can see the cornea, which is curved. And behind that, you can see the iris. And the iris is actually quite close to the cornea. And that's because the cataract is pushing it forward. The gap that you can see between those two lines down the bottom is where the fluid of the eye drains out. And you can imagine that if that drain is quite narrow because the iris is being pushed forward, the drain doesn't work as well. And I'll give you another image now to see what it looks like once the cataract has been removed. And you can see the difference there, that iris has fallen back and that drain area has opened up. I'll just go back so you can see it again. That's before the cataract with a very narrow drain. And this is after the cataract with the drain opened up much wider. And so you can see really that by opening the drain, that really helps the pressure of the eye, which is the main focus in a lot of glaucoma treatment. Now, here, the cataract surgery is excellent in patients with angle closure glaucoma. And I'm speaking less about that tonight, but cataract surgery and that is excellent. And then but even in open angle glaucoma, we know that cataract surgery lowers the pressure on its own. So that's really we're trying to come up with 3 take-home points today. And that's the first one, is that cataract surgery alone, we know it does reduce eye pressure. All right. So number 2. Now, again, a lot of the research that I do is looking into data and trying to understand which procedure is best and looking at big numbers. I'll try not to get into the data too much because I know it can get a little bit overwhelming. But yeah, I think it is important to understand where some of our decision-making comes from. So in terms of the second category of surgical procedures, this is where we do a cataract and we add something else in as well. And I think many people probably will have heard of the term MIGS before. I've tried to avoid using that too much in this talk because I think it does lead to a fair bit of confusion because people use that term in different ways, in different contexts. For here, I think it's worth just thinking of it, this is cataract and something else on top of it. And really, there's a lot of devices and a lot of procedures in this space. There's really only two at this stage that have large trials that have been done to compare with cataract surgery and see how they go. And that is the iStent inject on the left and the Hydrus microstent on the right. And each of these has got a 500 patient study where they give a group of the patients just a cataract surgery alone, and then they give another group of patients cataract surgery with one of the devices. And the first thing to say is that these blue bars tell you how much the pressure went down with just the cataract surgery. And you can see that here they were between 5 and 6 millimeters of mercury. So there is a definite reduction with just cataract surgery alone. However, if you did the cataract surgery and you put one of these devices in at the same time, you can see in the darker color there that you're up around 7 or 8 millimeters of mercury. So there is definitely more pressure reduction when you use one of these devices. And the other interesting thing is that, is there any difference between the devices? There's been a bit of study in this space, but really these are the best trials that show that there really is not a huge difference between these two devices in terms of which one should you use. Obviously, this was an area of interest for our research, and I'm the chief investigator of the Fight Glaucoma Blindness Registry, which is an internet-based registry that tracks the outcomes from a whole lot of surgeries. At the moment, we're looking at 6,000 or 7,000 surgeries, and we follow them over time. So some of the big studies that get published, they only go for maybe 2 years, and then we really don't have a lot of information of what happens after that. We're now following people ongoing, and so we have data 5, 6, 7 years over time and continue. And when we looked at our data for comparing these two devices, we found that, again, after the 2-year mark, there really was no difference at all. Patients did equally well depending on whether it was the iStent inject or the Hydrus with their cataract. And so I think that can make surgeons a bit more comfortable that either device is very reasonable to be using. And again, it's just for patients who need a slightly, they need a bit of pressure reduction, but not huge reduction. Often if we need huge reduction, we'll talk about that in the next section, filtration surgery. So the take-home point here is that cataract with another device lowers pressure a bit more than cataract alone, and we've got a couple of good options that have really strong evidence that they lower the pressure in addition. Now, I'm sure there'll be a few questions on other devices and other procedures within this space because it's a very fertile area. I tried just for this just to simplify it down and just look at the ones that have the higher quality evidence. There are certainly other procedures that many people use, and we can discuss those in a bit more detail. And for particular patients, maybe one device may be better than another.
Great, thank you.
So the final section that we'll mention is filtration surgery. Now, here, what we're doing is instead of putting a device in the drain of the eye, we're actually making a new communication between the inside of the eye and the outside of the eye. And this allows a big pressure reduction. Now, I know some people are a little bit squeamish with videos of eye surgery, so I've limited this to about a 10-second clip, and there's nothing too gory. But if you're not a fan of this sort of thing, you may want to look away for a few 30 seconds or so, and I'll let you know when it's safe to come back. So what I'm showing you here on the right-hand side is that I've created a little trapdoor in the wall of the eye, and this is part of a trabeculectomy. And what that trapdoor does is, if we just made a hole in the eye, the fluid would just flow out so fast that the pressure would go down to 0, and that would be really bad for the vision. So what we do is create this little flap, which is just like a trapdoor, and we put some stitches in it so that it gradually allows the fluid to regulate and flow out through that out through the trapdoor. And you can see in the diagram on the left that that's where the fluid comes from inside where the yellow is to flow outside up underneath the upper eyelid. So that's the trabeculectomy. And the reason, again, I'm showing you how this works is because it helps you to understand a couple of the other surgical devices that are available in this space. And really the two are the Zen gel stent, which is at the top, and the PreserFlow microshunt, which is at the bottom. And both of these devices are very small plastic tubes that come from inside the eye to outside the eye. And what they do is, instead of having that trapdoor, they use that small plastic tube. And because the tube has a fixed size on the inside of the tube, the idea is that you get a fixed amount of flow through that tube. And so it tries to make the procedure a bit more standardized and thereby improve results. If we go across to, the question really that is of most interest here is, well, which one works best and what's the best outcomes? And again, what we need is longer term data to be able to answer that. We're about to publish a very large series of Zen patients, over 600 followed through to 5 years. And what we found is that although it does get the pressure down, there's a relatively high revision rate. So about 10 to 20% of patients, so 1 in 5, 1 in 7, will need to go back to the operating theatre a second time within a year or two. It's also very dependent on the technique. So how the surgeon does the surgery influences very much the outcome. The PreserFlow microshunt, it's a bit more of the new kid on the block, and so we're still learning about the long-term outcomes, but it certainly looks like that if you're at high risk of having very low pressure after surgery, which is some patients, the PreserFlow seems to protect you from that. So if we're looking for that safety aspect, it's very good. However, if you need a big pressure reduction, then your pressure will not get as low with the PreserFlow as it would with, say, a trabeculectomy. So in patients who have normal pressure glaucoma, where the pressure is low to start with, I tend to steer away from either of these devices. And then really the thing that we're always comparing back to is this trabeculectomy. And because we've been doing it for, it was invented 50 years ago, there's a lot of data on it. It's the gold standard, which means it's really the reference for surgery. It is quite surgeon dependent, but I have to say that although it has got a bit of a bad rap in some circles, I think that if you have a surgeon who does a lot of trabeculectomies, it really is an excellent operation to get the pressure down and get things well controlled. And yes, it has risks, but the vast majority of patients, after I operate on them with the trabeculectomy, are often, oh, thank goodness, the pressure's so much lower, I'm off drops, and things are better in that space. So yes, there is risk, but it also has excellent outcomes. So that brings the third take-home point, which is that the type of filtration is really very much dependent on the individual patient situation. And so that's a discussion about your glaucoma and which is best for you in that space. So just to close off, these are the 3 points that I think summarize the situation, that cataract surgery alone reduces pressure. But if you add another device on top of that, then it definitely gets it lower. And we've got a couple of excellent options for that. And that filtration surgery is for more advanced glaucoma or where we need big pressure reductions. And really that depends on individual patient considerations. So with that, I'm happy to finish up and hand back over to you, Richard.
Fantastic. Thank you very much for that. Very, very interesting. I learnt a lot. Could you just give us a sense of what types of surgeries? Like, are these day surgeries, or are they where you're expected to stay overnight, or is it a few days in hospital for each one?
So, all glaucoma surgery for me is day surgery. And most of it is done under some sort of either topical anesthesia or local anesthesia. So it's painless, and depending on the surgery, between the shorter surgeries around the 10 or 15 minute mark, the longer surgeries are around an hour or so. But certainly most people would go home, sleep in their own bed, and then be seen the next day just to review and see how things are going.
Wow, that's amazing. Fantastic. That's great. All right, we'll get to the questions. So firstly, thank you, everyone. One of the things that I think makes this format so informative is the fact that we do get the opportunity to take questions from you all. So I'm going to read out some of those now. So first question doesn't have a specific person asking the question, but is it correct to assume that MIGS is a less invasive and better surgery compared to trabeculectomy?
Yeah, look, it's a great question. And it's one of the reasons why I tended to avoid using the word MIGS, because really there's so many different options in glaucoma now that for example, the PreserFlow shunt that I mentioned, which is just like a trabeculectomy, is very different to the eye stent that I mentioned, which goes along with cataract surgery. The risk profile is wildly different. The eye stent is much less risk, but doesn't give as big a pressure reduction. The PreserFlow has more risk, but gives a bigger pressure reduction. So the space is so broad that rather than piling it all into the MIGS category, I would say, like I did in the talk, is that when the eye stent, for example, did not exist, 15 years ago, and so it's replaced a lot of it has not replaced something. It has added to the options that we have. So it's certainly a good option for people where we need a little bit of pressure reduction, and maybe we would have gone and done a trabeculectomy in the past, but the eye stent allows us to maybe avoid that trabeculectomy in certain patients. So it's changed our treatment algorithm, but I wouldn't say that it's just a simple thing that MIGS is better in every way, and because it's always a trade-off between how well is it going to get your pressure down and what are the risks associated with getting that pressure down.
Fantastic. Thank you. Okay, the next question is from Colin. This is where you're going to help me with the pronunciations, but is canaloplasty an accepted solution for advanced glaucoma with difficult to manage IOP? And is it a low-risk procedure?
Yep, perfect pronunciation. So here I mentioned that there's a number of other different treatments that I didn't talk about in the talk. So the eye stent and the hydras, they both work on the trabecular meshwork, which is the inside of the eye, and they were the ones that I mentioned that we often do with cataract surgery. Now, canaloplasty is a way of modulating Schlemm's canal, which is part of that structure. And yes, canaloplasty is being used in a lot of patients, and it is being used in patients with advanced glaucoma. And the evidence for it is emerging. So there's certainly quite a few publications on it. It doesn't have the reason I chose those two to talk about it is because they're the ones that have big trials done with the US FDA. So it's unequivocal that we can show that they work. And so in certain types of glaucoma, yes, surgeons will think about canaloplasty as an option. And like I said, it really depends on the individual patient as to why you would choose that as an option rather than something else. But certainly it's in our armamentarium, and for some patients we will consider it.
I guess that's it generally, isn't it? You've got this toolbox, and what you're trying to do is match the right procedure to the right patient, and also for the objective of how much you want to lower the pressures.
Exactly.
Okay, next question from Colin. Can a canaloplasty be combined with the eye stent?
Absolutely. Yeah. I mean, you can combine lots of these different procedures together, and so long as it's physically possible. For example, if you remove one of the tissues where a device is supposed to go, you can't do that. But there is a possibility of combination. Again, the evidence for that is a lot weaker because there's not that many patients that would have had a canaloplasty and an eye stent, and so we don't have the opportunity to then see how that goes over time. We can make an estimate and see, oh, maybe that would do this. Whereas the benefit, for example, of the big trials is that we know that when we did this in 500 patients, this was the average result and this is what happened. So again, for certain patients in certain situations, we may consider things that are slightly unorthodox because it makes sense in their situation. But it's just a little bit hard to be sure. With my patients, I often like to say, well, look, I know that in this situation, there's about an 85% chance that we'll be able to achieve the outcome. And then these are the possible risks that come with that. But when we're going a little bit off-piste with some combinations, it's a bit harder to be sure of those outcomes for the individual patient.
Great, thank you. Next question is from Giovanni. What is often the best surgical approach for angle closure glaucoma cases?
Okay. So, as always with these sort of questions, the answer is it depends. But again, I'm going to break it down to be like the very simple sort of soundbite answer to this is cataract surgery, because we know that cataract surgery for angle closure glaucoma, it works wonders. Having said that, if you're 35 and you're much younger at the time of surgery, then that modulates things. If your optic nerve is in pretty good shape and you don't have a lot of glaucoma damage, then sometimes cataract surgery may be a bit enthusiastic. But for most people who have some optic nerve damage and they have a bit of a cataract, they're getting into their 60s or 70s, then cataract surgery is definitely my first go-to. And we were talking about evidence. Again, there is good evidence for this. There was a really big trial done. It was based in the UK, but it was across an international trial, which looked at people with angle closure glaucoma. And they found that if you had cataract surgery instead of laser, which is another option, is that your risk of going on to need a trabeculectomy was much lower if you had the cataract surgery. So again, if you're having cataract surgery done in a situation where the outcomes of the cataract surgery are really good, there and really safe, then cataract surgery is a fantastic option for you in this situation.
You might have answered this, but another question from Giovanni is cataract surgery risky for a person with angle closure glaucoma?
Yeah, so obviously every surgery comes with some risk. It's the nature of the game, and the risk from cataract surgery is quite low. So I think the risk of a major complication is exceptionally low. The possibility of a minor complication that's fixable is a little bit higher. Certainly in glaucoma patients, the risk in cataract surgery is higher. There's no doubt. They have things like, PXF is a type of glaucoma that increases the risk of a problem. Angle closure, because like I showed that slide where the front of the eye is really very narrow in angle closure cases, you just don't have as much space to be operating in, so you have to take a lot more care. There's more of a risk of a pressure spike afterwards. But I think, as a glaucoma specialist that does a lot of cataracts in patients with glaucoma, you learn what to watch out for, what to be careful of. And so the answer would be yes, I think there is a slightly higher risk, but not terribly so.
Fantastic, thank you. Question from Marilyn. If eye pressure starts to rise again after a surgery, does a patient have options for further surgeries? And how is this next type of surgery determined?
Yeah, great question. So this is exactly how we think. It's almost like a stepwise approach. So you could envisage a patient, for example, who, let's say they're 70, they've got a little bit of glaucoma, or actually, let's say they've got pressures that are a bit high, say 25, but they don't have any nerve damage at all from glaucoma yet, just the high pressures. Maybe, and they've got a bit of a cataract. Maybe we'll do a cataract and a stent to try and get them off their latanoprost eye drops. And then that might work for a couple of years. And then the pressure starts to rise and the nerve is now a little bit damaged. And so we might say, okay, well, now we go in and we do a trabeculectomy as part of it. And if that doesn't, and then that might give us, 5 or 10 years. And then we have the option, I didn't talk about tube shunt surgeries, but they're another type of surgery, which is a filtration surgery. So certainly you can do multiple surgical procedures. And often, if I'm thinking that this person's going to need a trabeculectomy within the next 5 years, and the patient's in their 60s or 70s, I'll often look to do the cataract surgery a little bit earlier than I would otherwise, because we know the outcome from a trabeculectomy is better if you've already had your cataract done. And so sometimes that's where I'll think, oh, look, let's do the cataract now, and it's a staging procedure. And sometimes if you're on drops and they're causing a bit of problem, we'll add a stent to that. And that might even delay the trabeculectomy for a few years. But we certainly do this escalation of surgery over time. And it's, I have a very large glaucoma practice, and it's very uncommon that we find somebody where you get to the end and say, well, look, we've exhausted all surgical options. And so, in fact, you can always repeat, you can put in a second tube or a third tube. So there's always options. And so I'd never be worried about the fact of like, oh, we're going to run out of options down the track. There certainly is. Our toolkit is large.
Oh, that's very good to know. I'm sure a lot of people out there will be glad to hear that as well. So another question, should SLT laser be tried in all cases before jumping into surgery?
So as I mentioned, SLT laser is really for open angle glaucoma. So let's put angle closure glaucoma to the side, because the treatments are wildly different depending on which one we're talking about. But in the open angle glaucoma, should SLT be tried in all cases? Look, I think that in many cases, it definitely is a good option, but not necessarily in all cases. There are some patients, if you come and you've got bad glaucoma and pressures are too high, if the SLT is not going to achieve the outcome that you need, then we may just be wasting time by doing that and not moving straight to the procedure that is needed, which is a surgical intervention. So there are definitely patients where we should just go straight to it. But I think we should at least think about it in all cases and think, why are we not doing this? And in some cases, we'll say, for this reason. In other cases, we'll go, yep, let's just do that as a good option before we try surgery.
Great, thank you. All right, next question, and this might be a bit general, but do your best. How long do the effects of surgery last for?
Yeah, look, and it's a really important question that my patients always want to know, because this is clearly why we're doing it. And it's one of the problems, like I said, with some of the trials, because they only last, the big studies that we do only last for 2 years. For most patients with glaucoma, that's a tiny window of time, and what we're interested in is much longer than that. And so that's the research that we're doing, is following a lot of these procedures over time, so we can help to answer some of these questions. It's very much dependent on the individual. Certainly for trabeculectomy, most patients will get a good 5 to 10 years, but it depends on, again, individual patient. For the, say, the cataract plus procedures, the slight problem we have is that if your glaucoma is getting worse and the pressure is gradually creeping up over time, the cataract with the stent might bring it down, but then your glaucoma was actually, the pressure was still rising over time. So in a couple of years, your pressure may have crept back up, not because the cataract and the stent is not working, but because your glaucoma was actually still getting worse over time. So I think it's important to realize that there's a couple of different reasons, is that the glaucoma progresses, and also the procedures definitely have a limited time span.
Great, thank you. All right, next question is from Amanda. How does the occurrence of extremely thin corners affect choices of treatment?
So I think probably that would be corneas, is what we're thinking of there, is that we know that if the front window of the eye, the cornea, is very thin, that is a risk factor for developing glaucoma. And I probably have to say that although it is a risk factor for developing glaucoma, in fact, I'm here in London with some colleagues who have just written some work saying that maybe we've overestimated the influence of thin corneas on the risk of glaucoma, but that's for another day. I think that in this situation, it probably does not influence the choice of treatment. What it does is it says that if your cornea is very thin, you're more likely to have glaucoma, and you're more likely to develop glaucoma, and your glaucoma may progress faster, but it wouldn't impact specifically which surgical procedure to undertake.
All right, fantastic. Thank you. One more question, just because I'm actually quite interested in this question myself. What is the process for massaging the bleb after a trabeculectomy, and why is it recommended?
Okay, so the bleb, I didn't talk about that so much, but when I mentioned that the fluid in the trabeculectomy comes from inside the eye to outside the eye, what that does is there's a space in between the wall of the eye and the conjunctiva, which is essentially the outer skin of the eye. And the bleb is the fluid that is trapped underneath the conjunctiva. It's like a fluid lake, or fluid underneath the upper lid. And what can happen over time is that you can get a bit of scar tissue that forms in between the wall of the eye and the conjunctiva. And so this area of fluid in here can become a bit less. So what massaging is actually, when I show that image of the trapdoor, what you're doing is pushing at the base of the trapdoor to try and encourage more fluid to flow out underneath the trapdoor. And so massage is to try and encourage that flow. If you're early in the process, so in the first month or so after the surgery, often the massage will help to get the fluid flowing more through the trabeculectomy. But as time starts to go on and all of the tissues are becoming a bit more fixed in their place, then the benefit of the massaging is a bit less. Fantastic. But the main reason for doing it is just to drop the pressure a bit further in the post-operative period.
Great, thank you. Really appreciate that. All right, well, listen, we've been going for over 30 minutes now, so I might take that opportunity to finish it up. But listen, thank you very much, Associate Professor Mitchell Lawlor, for giving your time so generously. Thanks for calling in from London, where, as I say, the clock's upside down to where we are in Australia right now. It's been a really fascinating chat. I know from a lot of the feedback that we get from our patients that this is a really key area that they want more information on. Obviously, going in and having any sort of surgical procedure on your eyes is a pretty big undertaking. So, and you're certainly the right person to ask about this. So thank you very much. I might just finish off with two things. One is, firstly, I do want to thank Glaucoma for actually sponsoring these live Q&As. They didn't actually just sponsor this particular event, but they've actually sponsored them across the entire year. So we really appreciate the support. And secondly, we have had some exciting news in the last couple of weeks here at Glaucoma Australia. Our very successful patient support program actually now has a new name. So no longer will I stumble over calling it the Patient Support Program. It's now actually called SightWise. So if you're not currently enrolled in SightWise, please make sure you go to our website or go to glaucoma.org.au/SightWise and enroll. One of the great benefits that you get from being in SightWise, it's totally free, I should say. And one of the great benefits you get is you can actually speak to our clinical educators via our 1-800 number at any time that you have a question. And as you can see on the screen there, the 1-800 number is 1-800-500-880. So thanks again, Mitchell. We really appreciate it. Great to see you. See you back in Sydney sometime soon. And thank you, everyone, for all the fantastic questions. And also thank you very much, Sarah, for helping put this all on in the background. So we look forward to seeing you on the next one.